I want to talk today about some work that that we've done at the Health Lab and the Crime Lab. I am here representing a team, and I want to take a moment to describe who is doing this work. One thing I would say is, if you're the smartest person in the room, you're in the wrong room. And fortunately, that is certainly no one at University of Chicago would ever tell you that you're the smartest person in the room. But this is really there's quite a lot of us involved in this effort. And so Andrew Tentner who's sitting over there, is a wonderful data scientist, among other skills, and has actually been the lead person on a lot of the empirics in this work. And Amy Spellman is kind of the logistical impresario of managing the relationship among different partners and just doing a lot of the important work to get this done. And then I'm going to talk about the outreach that we're doing now in a pilot called MHeart, and we actually, as you'll see, we try to identify people who are at risk of having a 911 type encounter that might include a behavioral crisis or the risk of violence, something like that. And what we're trying to do is in a proactive way, once these people are identified, go out, find them, and enroll them in services. And so Nuha, Jessica Smith, Atasi, and Loberta Livingston are, Nuha is kind of overseeing the management of the outreach effort, and Jessica Smith Atasi and Loberta Livingston are the two outreach workers. When we first started the effort, and people said, "Who do you want as your outreach worker for this project?" I said, "LeBron James." Because we're going out, we're trying to talk to people that have 911 calls there. There's a potential for behavioral crisis, you can imagine. And LeBron is we can't really afford him on our current budget, and he's a little busy. But it turns out that Jessica and Loberta are just fantastic, and it's actually a real asset for them that they're not LeBron James when they're dealing with a lot of people who might be frightened by a sort of very aggressive kind of approach. Ruth Kaufman is the executive director of the Health Lab, and Rosanna Ander is executive director of the Crime Lab, and it's key people. Tony Sadler is here. I think I saw Tony come in. Tony, are you here? Tony and I work together on some of the qualitative work that I'll be talking about. And Tony's interviewed a lot of first responders, and ranging from police officers and ambulance folk to other stakeholders to try to understand in a very practical way what's working and not working. Alliston Stinson here at SSA is a co-author on our AJPH piece that I'll be mentioning some from. And David Meltzer is the director of the Health Lab, and also our colleagues, of course, from different organizations, the police department, the fire department. OEMC is, they handle the 911 calls. And Thresholds and NAMI have also been key partners for us, as I'll discuss. So now that I've basically used up all of my time describing. Any questions? So I have a pretty action-packed roadmap. And I thought what I'd do is I would start with the nature of the problem and how we try to identify people at a risk of behavioral crisis, behavioral health crisis. There's no perfect term to describe the things that we're concerned about, because there's diverse interactions with first responders where people don't behave in a way that is expected or desired by police officers or others that they're dealing with, and what happens from there. I want to talk some about the mundane realities of police work and other types of first response, which actually turn out to be really critical, easily overlooked variables in whether someone will be will have a safe encounter with first responders. And what we can do, the opportunities and challenges that we have when we have data that is linked across the different data sets that we have. From 911, police, and ambulance, administrative data, where we try to identify people, places, and events that might be predictive of a likely concerning call. Then I'll give some descriptives and predictive analytic results and tell you a little bit about our pilot. Right? let's see, have I left anything out? Is that, so we have about 3-4 hours today. So I know, by the way, my preemptive surrender slide, yeah, the fonts are going to be all screwed up in a lot of my slides. For some of you that may be really upsetting, I just have to warn you ahead of time. By the way, I should say that I'm not going to have any videos today. I thought about showing a couple of videos and decided, you know, a lot of us could be just as well not watch one of those videos. But I will describe in the first 10 minutes or so some incidents. And so if you want to come back and go out and get a cup of coffee, that's fine. I mean, because I will describe interactions where tragic things happen. And you know, these days it's not, you know, it's upsetting. I actually find when I talk about encounters with people with mental illness and disability, I'm much more likely to get a reaction from my audience where someone is moved or upset than I am when I talk about virtually any gang crime or something like that. If I say someone got shot in the face or whatever, people are like, I see that on the news every night. When I talk about someone with a developmental disability who has something bad happen to them, someone starts to cry in the audience because they're like, that's my son. So I respect if anybody wants to just take a break and come back. So I should say that some of these crises that happen, the ones that we think about, we often think about the stereotypical person with a serious mental illness. You know, the schizophrenic guy who's talking to Jesus out on the midway, and Jesus is carrying on the conversation with him. And we sort of have images in our head of what kinds of interactions we're thinking about. And it turns out that actually there's a tremendous variety of reasons why people can have a behavioral crisis that involves first responders. And some of them match the images that we have or that first responders have in their head of people in that kind of crisis, and some of them don't. If I'm telling a police officer, if I'm cursing that person out, and I'm behaving in a really wild way, and I'm a sort of 62-year-old dude with a little razor stubble, and I'm wearing like a denim jacket, maybe I'm a vet, a lot of the cops are like, oh, I get that. There's a box that I can put that in. If I'm a muscular 22-year-old guy who's doing exactly the same thing, there's a different box. And that's a little different. And there's a lot more question about, in the officer's head, about, hey, what are people going to think if I allow this guy to scream at me? And things like that. I won't talk today about some of the broader policy challenges. Medicaid expansion is a key tool to try to help people that have these types of encounters. Almost everybody that's in our data is basically insured through Medicaid now. We don't yet know how to use that as the most effective tool, but that's probably another talk. So let me start. Of course, the most famous case that many of us are thinking about is the LaQuan McDonald shooting. And also the Quintonio LeGrier shooting would be a second one. How many of you have seen the LaQuan McDonald video? Have seen the video of LaQuan McDonald? There's a couple of things that are striking about that video. One is the complete disjunction between what happened and what various people said happened, of course. But the other thing is, if you watch that video right up until the time that Officer Van Dyke drives up, it actually could be a training film for positive police interaction with someone in a behavioral crisis. The other officers on the scene are keeping their distance from him. They're giving him time to calm down. They have him in a space where he's not going to get hurt, where no one else is going to get hurt, and where the right thing to do at that moment is basically nothing. And then Officer Van Dyke drives up and kills the kid, and you know, horribly. And then all the police did all the right thing. They all then lie about what happened, even though they all understood exactly what had just happened. But that's the most famous case, and Quintonio LeGrier and the Betty Jones case, where the police came to a home. Mr. LeGrier was aggressive, and there's some question about exactly what happened, but officers ended up shooting him and Betty Jones. these are kind of the obvious cases that we think of. And I served on the Police Accountability Task Force De-Escalation Working Group, where we were trying to come up with ways to improve police responses to these kinds of calls. Okay? And I must say, it was a very difficult experience. I was very happy that I did it, to be participating in this group. The city of Chicago, of course, has made a number of efforts to try to improve its response, and I'll get into that in a minute. Okay? So let me start with a different kind of story. Anybody know who Robert Saylor is? Tony, you don't count. Tony and I wrote a book chapter that tells about this story, among other things. So Robert Saylor lived in Fredericksburg, Maryland, and 26-year-old man, lived at home, lived with Down syndrome, goes out to the movies with a young woman named Mary Crosby, who's his young attendant who drove him to the movies. So they see the movie, they come out. Am I making people nauseous by moving around? Sorry, that's kind of what I do. So they come out of the movie, and he starts to get really agitated. And so Mary Crosby calls up his mom, and she says, he's really agitated. What do you think I should do? And his mom says, why don't you go get the car, bring it around, maybe he'll kind of calm down, and I'll come down and see maybe I can help. So Crosby goes out to the parking lot to get the car. While she's gone, he goes back in the theater and he sits back in his original seat. He was agitated because he wanted to see the movie again. And he just didn't want to go home. So you're not allowed to see a movie again without paying. By the way, some of you that may be news. So Crosby parks the car, she comes back, and the manager is confronting Mr. Saylor. And Saylor's getting really mad because he wants to see the movie. And Mary Crosby is saying, please don't touch him. That's not going to work real well. But of course, the manager looks over at this chicky 18-year-old who's the attendant, and he's like a dude my age, and he's like, I'm going to listen to this 18-year-old telling me how to do my job. So he gets into it with Mr. Saylor, gets nowhere. He decides he's going to call mall security. So 3 off-duty sheriffs show up who are the mall security. And Crosby says, please don't touch him, whatever, that's not going to work real well. They all look at her and they have the same reaction that the manager did, like we're going to let this 18-year-old tell us how to do our job while this obnoxious guy is screaming at us. And so they decide that they're, and then they start to get into it with Mr. Saylor. He ends up on the floor under them. And his mom arrives just in time to discover that he has just died from asphyxiation in the struggle with these 3 officers. He's a husky young man. The officers are charged with homicide. They are acquitted. Although the judge is scathing, he basically points out that this guy died in over a $12 movie ticket. But the officers said, we followed our training. Our training was to continually escalate the situation until the subject is compliant with our instruction. And he just wasn't compliant. And, if you're sitting in a chair, if right now I went over to Keith, well, imagine that there's somebody more fit than I am and 25 years younger, and I'm like trying to get Keith out of this chair. It would actually be hard for me to do that without him hurting me or me hurting him. And the sad thing was the officers were correct. They were following their training. And that's precisely, of course, the problem. Another case, by the way, I should say that among people who have intellectually disabled loved ones, this is a very common issue. So Rebecca Feinstein and I wrote a paper not one of the ones that Colleen mentioned. See, you didn't mention the right paper to massage my ego. You know, you can't just mention random papers. It has to be the one that I'm thinking about at the moment, which you're supposed to figure out by telepathy. So we interviewed a bunch of caregivers whose loved ones had Fragile X syndrome. And we found that, consistent with national studies, about a third of the adults were being regularly injured by their sons. And, you know, and the quotes that we got, sometimes, by the way, we had these conversations after I would turn off the tape recorder, and then we'd get to the real stuff. And you know, people would say stuff like, he's not aggressive or violent, I just know what triggers it, but every now and then I screw up. I touched him at breakfast, and I forgot that he doesn't like that. Another case where this woman's son was sitting at the breakfast table, and he just picks up a coffee mug and he just whips it at his dad, hits his dad in the face. They call the police. Police come. He fights with the police. And then the mom goes down to the police an hour later and says, please, I just want to bring him home. He's calmed down. He's going to be okay. One of the most difficult questions that every family caregiver faces who has that issue is, do I feel comfortable calling the police? You know, one of the problems with stories like what happened to Mr. Saylor is it's such a tragedy for the individual, but it also means that people have to think about, you know, if I need a first responder, do I call? How many of you had heard of that Saylor story before? If you had a loved one with Down syndrome who was a large young man, you would know this story very well because it would have been on your Facebook group that you go on periodically with other caregivers. And I know this because right after this came out, my wife and I were sitting at breakfast one day, and she just said, you know, I just want you to know, whatever Vincent does, I don't ever want you to call police. Just very matter-of-factly. She's like, I don't care if he's beating the crap out of me. I would prefer that than the risks of having someone come in who doesn't know him, who he doesn't know, in a volatile situation. And so it's a tremendous problem from many different dimensions. So here's another case, by the way. Remember that guy at O'Hare Airport who was overbooked on the flight? This was such a great example, by the way, of middle-class mishigas. So this guy's on a flight, he's dragged off, and the conversation among all my friends was like, wow, United Airlines service really sucks. You know, he was overbooked and they dragged him up. Personally, I don't actually care about United Airlines service on a flight, but here was a guy, he was on a flight, was overbooked, and he didn't want to get out of his seat. And the officers behaved basically the same way that they behaved towards Mr. Saylor. And the result was that this guy got quite banged up. Hey, come on in. So police have lots of interactions where the right thing to do is nothing, but where that's hard to do. You know, imagine how much better United Airlines would be right now if the officer had just stopped and said, is there anybody here willing to get off this flight if I just give you $1,500? We'll figure out how the airline will pay for it. Yeah, and say to the guy, look, I'm not going to drag you out of the chair. If you don't get up, you may be banned from United because United has asked you to leave. But it's actually quite dangerous to manhandle someone in that situation. And but both the officer and the man involved, Dr. David Dow, sort of felt cornered and didn't quite know how to respond. And the result was a frightening incident. So how can we deal with situations like that? So one of the things, so if we think about Mr. Saylor's situation, one thing we might do is give officers training about developmental disability. And that would definitely help in some ways. For example, if someone's developmentally disabled, you never want to push them down prone because people are more likely to have a morphological issue where they can asphyxiate the way that Mr. Saylor did. But basically, you don't need to diagnose anybody, and in fact, when officers and trained mental health professionals try to diagnose someone on the fly in a really volatile situation, they generally get it wrong. And even if they get it right, the right answer tends to be the same, no matter what the diagnosis is. So training is valuable, but sort of figuring out how did I know that this guy had Down syndrome rather than Fragile X syndrome or fetal alcohol, that's not too valuable. Another thing is to think about the cultural and mundane practicalities of police work, and I'll mention some of the work that Tony and I did that relates to this. And Tony can correct me if I'm getting anything wrong. So less focus on recognizing specific conditions, more on applying time and distance principles to that situation. Think about Mr. Saylor. It didn't really matter that he was developmentally disabled. He could have had any number of issues going on, or no issue, but he just was a really angry guy who didn't want to get up out of his seat. And the only thing that they really had to know was, don't touch him and don't get him more agitated while we figure out what to do. Figuring out what his mom was on the way. The more time you have, the more ability you have to get someone on the scene who can help you, or you can just get more people, because if you do have to be coercive, it's a lot easier to not hurt someone if you have 10 people than when you have 3 people. And in fact, I was talking to the police chief of Burlington, Vermont, and he was saying we do not train our officers. We train our officers a lot in what to do if you are attacked by 4 people. We do not train our officers in what do you do if you have 4 people and there's 1 person that you're trying to subdue. So like 3 guys jump on the guy, and then the 4th guy says, what do I do? Oh, maybe I should punch him in the head, because I don't know what else to do. And there's a lot that you can do, though, if you can have time and distance. Another thing you can do is think about policies by people that are not the police to understand how they behave. The theater manager, I wonder what kind of training he got to deal with an unruly customer. And did he get any training? One of the most striking things in group homes and institutions is the way that they use the threat of calling the police as a method of behavioral control of the people who live in these institutions. So like, Dylan, if you don't calm down, I'm going to call the cops. And the purpose of that is to get you to shut up and calm down. Now, you don't calm down, and say you're a person with some sort of a psychiatric or intellectual disability or whatever you have. So we call, like my brother-in-law lives in South Holland, Illinois. So he lives in a group home. So you call the police. So the police officer comes. He's a 26-year-old guy who's basically trained as a suburban police officer. And he walks into the house, and like, he's like, what do you expect me to do? Your job is to serve this person with this disability. This is like what you're trained to do. And like, you have just told me you cannot control this person, and now you've called me. Now, of course, there is one thing that that officer can do, which is that he can handcuff Dylan and take him away. And that's certainly an available thing. The police don't want to do that if they can avoid it. And one of the things police discover, by the way, is what they are specifically not wanted to do by the staff is to actually mediate the situation. So I wrote a piece in the Washington Monthly. It turns out that in Tennessee that there's some of the real experts in this stuff are in Tennessee. And an officer who does a lot of work there was saying that a man went off to work at his group home, and the staff gave away his dog while he was at work. So he comes home, and he's like, where's my dog? And he flips out because his dog is gone. And he was like, he loves his dog. And so the response of the staff is to call the cops. So the cops come over, and they're like, why'd you get rid of his dog? And the staff are like, that's not why we called you. And had the police behaved really, had the police done something badly in that incident, we would have said, wow, the police really screwed up. It's not clear the police are the fundamental problem in those kinds of stories. We expect them to be psychiatrists, social workers. We expect them to take on an awful lot of roles. Yeah. So now let me get into the work that, the empirical work I'm going to show you now. Andrea must be watching this one. When is he going to get to the actual work that we do? So it's coming. So one thing that we like to think about are the different ways that we might intervene to predict that someone might have a problem and to understand the type of intervention that might be effective. And in a lot of our work, we've talked about person-based interventions, event-based interventions, and place-based interventions. So a person-based intervention is, we know that Laura's had 3 problems in the past. We kind of know that she's at risk. Can we do something to help her? And what are ACT and FACT? Anybody want to tell me? Yeah. Ms. Smith? And what's that? What is that? And so you can go to the person. We send a team that is trained, an ACT team, to the person and try to help them. And what's FACT? Anybody know what FACT is? That is one that's forensic assertive community treatment. It is more suited to, is tailored to people with specific criminal justice challenges. There's also event-based interventions. Maybe there's things that happen in the context of that call. Someone calls 911 and there's something about the way that event is described that you say, wow, that's a high risk. Maybe there's somebody who's being combative. Maybe there's particular keywords that alert you that there could be a problem. And you can, and we're of course doing a lot of work in predictive analytics to try to understand that better. If you knew that there was a problem, you could send out officers to that 911 call with special training, which I'll get to in a minute, called CIT. And there's also place-based interventions. There are places like the last stop on the L, where you know that there's just going to be calls. It was actually kind of humbling when we first started this project, seemed like 10 years ago. I went out to, I don't think either one of you guys were there. I went out to talk to the EMS people. And we had all these statistical analyses where we had zip codes and things like that. And we would say, we think there's something going on that's really interesting about that neighborhood. And I was sort of going on kind of like I'm going on now. And at some point I paused for a breath. And one of the guys around the table said, dude, that's the end of the red line. Like, there's nothing interesting about that neighborhood. No one that we're having calls for lives in that neighborhood. It's the end of the red line. And turns out the EMS people, by the way, are really interesting and smart. And they have less reason to be guarded than many other first responders in the system. If you think about what the situation the police are in, it's a little hard to have a candid conversation with police about some of these issues because of just what they're facing right now. Well, the EMS is a very different vibe. They're, but you can imagine that you have homeless shelters, group homes, places that have real capacity and where they have frequent events that we could actually do some sort of a systematic response. So you could say to the staff at Union Station, here's what you do when XYZ happens. And there's also interventions that would work better for, say, your house, like Smart 911. Does anybody know what Smart 911 is? Suppose you have somebody deaf in your house, or somebody with diabetes in your house, or someone with severe depression in your house. You can actually register with something called Smart 911. If you make a phone call, so you basically link your cell phone to a Smart 911 record, and if you ever call 911 from the cell phone, data come up for the dispatcher where they say there's someone who's deaf in the house, or there's someone with autism in the house, so that the first responders, when they come, kind of know what they're getting into. And this guy who's not responding to me, that's because he can't hear me. But it's not unusual for people who are deaf to be injured by police because they're not complying with police instruction. When you think about that, that's kind of obvious, but you wouldn't necessarily think about that. And one of the obvious empirical questions is, how much do these 3 categories overlap? Is that guy in Union Station who's having a crisis, is that the same guy that we've dealt with 3 other times? Yeah. So I should mention that the officers do receive training in what's called CIT, and Tony and I did some work on this. They have a 40-hour training at the police department. They have about a whole 50 minutes on developmental disabilities, but they really do is a very worthy thing. One of the things that they do, for example, is they have a hearing voice simulation where they ask the officers to put on headphones where they're hearing voices while someone is trying to get them to comply with various instructions. And the idea is you're trying to get a sense of what is it like to be someone who's hearing voices and they're trying to respond to you. A lot of the officers who are drawn to CIT, by the way, are people who have a family member who has had an issue, or there's someone who's been in the military and they've been sensitized to that because of PTSD in the military. Disproportional number are women, so quite a number of officers have gone through these CIT trainings. So when Tony and I tried to look at these issues and tried to understand why do these systems fall short, we discovered a couple of things. One is that resource and time constraints are just really fundamental. And a lot of the officers know that the time and distance paradigm is what they should do. But that's not always easy to do. And I'll get to why that sometimes doesn't happen, even though we would all like it to happen. Also, a lot of the people that they deal with, they've seen before. People talk about the familiar faces. There are a number of efforts to try to just get to talk to officers and try to find out who do you deal with on your beat a lot who has these kinds of issues. Also, a lot of familiar issues about coordination challenges. There's the people who take the 911 call at OEMC, there's the ambulance people, and there's the police people. They're all involved in an effort to try to serve this one person. You think about all the different coordination problems and playing telephone in that process that could cause problems. And then the other thing, which is the embarrassing part, what if officers do everything right? What happens after that? That's very often where the thing falls apart. So resource and time constraints. So this is a story that I heard when I was on the de-escalation working group. A woman comes who's a CIT officer. She gets called to a house on a Saturday night, and there's a guy sitting on his bed who has to go to a psychiatric hospital. And she's doing a great job calming him down. But it's Inglewood and it's Saturday night. And while she's talking to this gentleman, her phone and her supervisor's phone, her supervisor's behind her, their phones are going crazy. They're getting texts. There's a shooting over at 79th and Marshfield. There's a this going, hey, what's going on? And at a certain point, her supervisor dashes past her, jumps on the guy, cuffs him, and drags him to the police car. And he's just like, I just ran out of time to deal with this call. I'm sorry, I had to wrap this up. I didn't have 45 minutes to do a little OJ trial with you, while all these other stuff was going on. So at 2 o'clock in the afternoon in Bucktown on a Tuesday, the police are going to react totally differently from Englewood on a Saturday night to the same guy. And that's resources. We often say here at SSA, I think a lot of us feel like we overinvest in policing compared to other things, which is true. But a large police force in certain contexts is equipped to be more humane to people than one that's kind of undermanned in these kinds of situations. That make sense? Okay. So a lot of conversation that we had about just the mundane realities of police work, which get less attention than some of the big issues that we're used to debating in public policy. The shortage of mental health resources is, of course, an obvious challenge. And, I wish that the gatekeepers for mental health services in Chicago were guarding Hillary Clinton's email. I think she'd be president right now, as far as I can tell. Getting people access to the services that they need is just really difficult. But that joke was a lot funnier than you guys gave me credit for. I just want to note that. The most frustrating thing for officers, they do everything right, and then 2 hours later, the same guy is on that same corner doing whatever it is that they got called for the first time. And they bring the person to the psychiatric emergency room, and just nothing happens that addresses the problem. The next time the police officers face that same guy, what do you think they're going to do? They're much more likely to take him to the jail. So at least I know something's going to happen at the jail to try to deal with this. because the jail seems to be doing a better job of dealing with this guy's mental health problem than the place I just went. You do not want officers to be in that headspace. There's a lot about the way that, what is the role within the police department of this type of service? Police are a culture like every other culture, and you know, if the status reward system is, there was this huge dude who tried to attack somebody and I was able to subdue him and I cuffed him and I got him in the car and all my buddies are like giving me the high five. But if I talk that same guy down and I get him into my car and there was no violence, people are like, that's not interesting. That sets, you know, that sets a set of norms about how what's valued by officers and what kinds of skills officers have that their peers respect. And if dealing with people with mental illnesses and developmental disabilities is kind of the warm and fuzzy stuff, that may not be the greatest way to incentivize it. Okay? I'm going to skip over I will say that there's multiple calls to the same addresses and the same individuals. It was amusing talking to the EMS people, by the way, because when we listed locations, they would start cursing about that location. And they would say, those people at that shelter, what is the matter with them? And they keep calling us. We would get a call, schizophrenic man at site. So they come, are expecting a crisis. And there is, in fact, a schizophrenic man at the shelter, but he's holding his foot out, and he's like, yeah, I have a fungal infection. And like the procedure is we always call 911 when anybody at the shelter has a fungal infection. So like they're ready for a guy in a mental health crisis, and it's just a guy with a toe problem. And so quickly, before Andrea comes back, I'll do the entire part of the talk that she's the first author for, so she can't correct me. Tony, did I screw up anything badly? Mildly? So let me get to the administrative data analysis. And I should say Andrea is the first author in this. And we have collected hundreds of thousands of records of basically every 911 call in Chicago linked to police and fire responses connected to that. And we've done, we know a lot about what the dispatcher said when the call was made and the notes that they made. We also know a lot about what happened when the ambulance folk or the police folks showed up. And we can look at the impressions and the patient complaints and so on. And so one of the first things we did is we tried to identify calls that were likely to include the risk of a behavioral health crisis. So words like agitated, anxiety, crying, tearful, violent, hallucination, irritable, and so on. And and EMS impressions, combative, so on. Words like that. Okay? Sometimes we had illicit drug keywords in there. There's a bunch of issues about how to think about intoxication and heroin use that are in the mix. We know if the police were on the scene. The EMS people will tell us. We actually don't. It's a little complicated to know whether there was an arrest made in that moment. We actually know if that individual was arrested that day or that we know the time of the arrest. We actually don't know if they were arrested specifically in that incident. There's a bunch of complexities in the data. Now, there's a lot of complexities about this data. I was just talking to John Schneider while I was wolfing down my sandwich, getting nervous for the talk. And and one of the things that I was mentioning to him is that 80% of the work in this work is the really boring stuff. You know, when you go and you give a talk at an academic conference about this, they say, did you use a random forest binary classifier? Or did you try ensembles and boosting with that? And the actual work is like, you know, we see that Latrell Murphy was arrested, and we see here that Latrell Murphy was arrested. Is that the same guy? Like that's most of the work, is like the data cleaning, assembly, birth dates don't match. You know, when you think about it, a lot of these data are collected from people in a social process where everybody's under a lot of pressure. And, you know, if I went to the hospital, probably the data about me would be pretty clean. You know, someone came to my house, I had some sort of physical problem, I had a driver's license, There's all kinds of paperwork. I'm in my actual house. The data is going to look great about me, probably, in a data quality sense. The homeless guy that's on the L, who's asleep when he gets to O'Hare Airport, he doesn't have any particular ID on him. He happens to be a Chinese guy, and the officer doesn't quite know what his name, like he sort of heard the name, but he doesn't really know how to spell it. You know, did he say Jean Wei, or did he say something else that, like, he writes it down as best he can, and it may not match. You know, that's just the reality of trying to work with this data. And it's interesting, I've been learning a lot about machine learning and artificial intelligence for a lot of this work that I'm doing. And I was at a lecture by someone named Andrew Negg, who's one of the big entrepreneurs in AI. And he said, you may wonder, how do we set up a defensible business model for predictive analytics? You know, for the experts in this field, when they pick up a phone and they see some sort of a cool app, if you're in that business, you basically know how that app works. You know, the algorithms are pretty transparent. How do you know? So how do you make a successful business model when there's that level of transparency? And he says the answer is we have data that nobody else has. We have relationships that nobody else has. And the entire comparative advantage of Urban Labs, to a great extent, is we've had 10 years of data use agreements, IRB stuff, relationships with partners, the capacity to do all the front-end stuff that allows us to do the algorithm that's going to be in the paper. And you know, if you're a doctoral student thinking of doing machine learning applications, things like that, the front end of the pipeline is where so much of the actual work is done. And I wish I spent more time in my training being good at a lot of the basic blocking and tackling of writing reproducible, high-quality code to do all this stuff. Okay. So here's just our mandatory flow diagram. You can imagine a call comes in, the dispatcher receives the call, various things can happen, and there are these different data sets that are created as a result of that interaction and what the OEMC dispatchers decide to do with the call. Right? So, and we're trying to understand, if we look at all this linked data, what can we get out of it? So here's, Andrea made this. Don't ask me why I have this orange arrow there. I just kind of liked it. But you can, so we have a stream of data. We have arrest data on 61,977 unique individuals, and police actually have a fingerprint validated IR number, which is a personal identifier, which is very useful. Fire department doesn't have that. You know, they don't fingerprint you when they take you to the hospital. So we have this stream of data that comes from the ambulance data and the arrest data, and then we try to merge them using fuzzy matching to get unique individuals out of each of these two data sets, and then trying to merge these two data sets together. And you know, this is, and you know, Andrea's done all this work, and it's actually kind of amazing. And if you think, and then if you look at the volume of this, you know, it's a big lift. And when we merge these data sets, we try to kind of look at two different groups of people to focus on. I'll tell you a little about two different groups of people. One are people that have a behavioral health involved ambulance event, and they have police involvement. Okay? So we have 1,842 people in the city of Chicago who sort of show up in the Venn diagram in the intersection. And then within that group, we also want to get a sense of people who have some sort of a chronic issue that doesn't seem to be resolving. It's actually kind of interesting if you think about who these people are. They're not, if you think about, so these are people that have had at least 4 events. And we also said they have to occur in multiple months. And within the first one, in the first 5 of the 12 months that we have of our window of data that we have. Okay? And this is basically so that we could track them. We wanted an early event, somebody that had an early event. It's a somewhat arbitrary way to draw these definitions. You could do other definitions that would be reasonable, but the idea is this is a group of people, we came up with 330, where they seem to have this chronic issue. And we tried to understand who these people are. Okay? And they're sort of an interesting group. You can't be Jeffrey Dahmer in this group. Why can't you be Jeffrey Dahmer and be one of these 330 people? Because they're not going to let you, you're going to get locked up. You're not going to have a chance. You may be Jeffrey Dahmer in the last event, but if they arrest you for murder on the first incident, you're not going to have an opportunity to be out and arrested again. So you're someone who has a chronic issue, but they're often the kind of urban rabble of Chicago. People that are shoplifting, people that are yelling at people on the train, people who are who are being intoxicated. But they're not like people committing armed robberies necessarily, that kind of thing. Some of them are. Okay? It was striking, by the way, talking with the EMTs about some of these folks, they would recognize people. We tried to fuzz everything up, but you go talk to them, they're like, oh yeah, I know that guy. Because Chicago is a big city, but 330 is not a huge number. So this is their business. So here's just what the Venn diagram looks like to get what we call the at-risk population. 1,842 people that are they've been both in the arrest data and in the mental health data. And then within this at-risk group, the 330 that are sort of the subgroup that are of particular interest. And these are the kinds of folks that you think we might be able to serve with some sort of proactive intervention. One thing that we found helpful, you can sort of see a lot just by looking. Who said that? Yogi Berra. Yeah. So one thing that was really interesting was just going through particular people's records. It's almost like a little qualitative study. We just would print out all the ambulance and police data for a given person and just start reading it through. Andrea, please chime in if you feel like it as the Spirit moves you. I sort of found this one of my favorite parts of the whole project. And so here's a particular person. We fuzz up the data a little bit just for confidentiality, but what's on the top side is their arrest history and what's on the bottom is their ambulance history. But one of the things that we found with all of these folks, people don't wear a white hat or a black hat. You sort of look at a particular person and you see he went to the fire station to try to get help for his addiction. He had a really serious physical health problem. You start reading stuff in the ambulance data and you say, boy, this guy's like a poster child for Obamacare and he really needs help. And then you read the police stuff and you say, well, there was the time that he was pushing women on the L. And you're like, whoa, this guy's a little dangerous. And a lot of people are complicated, particularly people with significant behavioral health challenges. So here you have a person who has a misdemeanor arrest harassing someone on the CTA. Then another arrest, retail theft at grocery. I personally was struck by the number of people arrested trying to shoplift alcohol from Walgreens. That was like one of the most common types of crimes. Anything else? Was anything else common that comes to mind in this?
And there was a lot of just like minor assault kind of things. So the major things were larceny and minor assaults.
And some of them were sad, like larceny of underwear and socks, or stuff, survival crimes. But also some of the assaults come out of that. Like there was this one woman that was in the data set, and she was shoplifting something minor, and you're like, well, who cares about that? Except that when the shopkeeper came out, who was an 80-year-old man, to try to confront her, she punched him in the face. And all of a sudden, it's like, it's a problem. So here you have a person who's had an alcohol thing, and then you can see that there's something going on where there's 2 ambulance calls within hours. Psychiatric episode involving alcohol, taken to the ER twice. Then you see a whole series of things going on. They had some kind of a crisis in these 40 days. Patient requests rehab, transported to the ER, and then they get arrested. They kind of disappear in the data. We don't know. Maybe they were in the jail all that time. Something happened. So this is, for those of you that are live tweeting this to Hollywood, don't live tweet these tables because there's a revise and resubmit right now. that we're on. But it's kind of interesting to look at the top people. So that, our top person had 42 emergency events in a year, and 5 of which involved police. Was arrested 5 times, twice for a felony. And you can see these folks are pretty busy. And so these top 10 folks are having lots of interactions. One of the things that's interesting is that some of these folks you would not have particularly recognized if you just had the police data or just the ambulance data. But when you look at both of them together, you're like, wow, this person is having some intense needs over this period. And so if you think about, if you just had, the arrest events, you would basically be ignoring a lot of the people on this list. A lot of people, by the way, arrested for outstanding warrants, things like that. So in terms of the top 10 places, there's a shelter, there's a mental health facility that calls 911 a lot. The airports, I was surprised at how many of these calls were the airports. Some of that is because they're at the end of the blue line, but they're also, I don't see why the O'Hare International Terminal, there would be a lot of calls or something like that, but there are. And the bus station. One of the things that we've tried to look at is who are the people that are being interacted with in these locations. So, so we've done some work on that. Just in terms of who people are in these two groups. See if I can get this laser pointer. The at-risk group and the high use group. So average age about 35, and there's mostly men, not surprisingly. Majority minority, but a little bit less than just if you had police records alone. Although it varies a little bit on how you slice the data. There are lots of people who are homeless, and these are people who are indicated as being homeless in, when the EMTs interact with them. So there's some sort of an indicator in the data about that. One thing about this term homeless is it's a very elastic category. There's a lot of people who are precariously housed. Imagine that you're a person who has some sort of an issue where the police are being called periodically about you in behavioral health emergencies. You can imagine that if you're sleeping on your cousin's couch, that's not always a very stable setup. So by various ways to think about this 25.8% number, I think a much higher percentage of those people are precariously housed. Am I?
Yeah, and actually in updated analyses that take into account the dirtiness of this indicator, it's more like 35%.
So there's,
Who are actually indicated as homeless, so even higher precariously.
So yeah, one of the problems, like homeless, is just think about all the different ways that the data can be slightly screwed up. That someone just forgot the E and all that kind of stuff, and and so if you look at how active people are, you see particularly the high use group. They get arrested a lot, on average 3.6 times per person in a year, mostly for misdemeanors and relatively minor things, but they are arrested for felonies too. They actually don't account for a lot of the arrests in Chicago. And in fact, these groups don't account for a huge percentage of all the mental health related ambulance calls in Chicago, but these particular people are quite active. And if you look at the locations, I don't think I'll spend a huge amount of time on this, but we looked at how many people, say at Union Station, if they had an ambulance call that was related to a behavioral crisis, how many of them were high users? And they are more likely to be high users than in other spots, although the typical person in a place like Union Station would not be. Lots of our high users at some point are in, say, the top 100 addresses or the top 10 addresses in Chicago having at least one of these events. Yeah, another thing that Andrea did was to do a kind of cluster analysis at what kinds of words tend to come together in the event descriptions that the ambulance folk give. And I'll just mention that there were 5 subgroups that come together. These words tend to often be mentioned together or regarding the same person in multiple events. And we then went to our thresholds partners and we sort of said, which of these subgroups kind of matches your sweet spots for services that you could deliver? And subgroups 1 and 4 seem to be the ones that they valued highly. And I'll come back to this in a minute, but you can imagine that staff safety becomes obviously something to think about when you think about some of these keywords. So now I get to the predictive analytics. So we identified these groups of at-risk and high-use people just in the data. Ralph showed up 5 times. Can we predict who is at risk for the next 6 months? So this is where we really use the machine learning predictive analytics. And the goal is to try to identify people at risk and then, rather than wait for a 911 call, send out staff to try to enroll them in services. Okay. So what I showed you before is kind of what we sometimes call the prescriptive strategy. Let's look at who actually showed up a lot in the past. A predictive strategy tries to use statistics to predict people. And what we can do with our predictive strategy is we have lots of data over this period, May 2016 to April 2017. We can then say, okay, what's going on in the follow-up period? And we predict well what's happening. So this is meant to be an artistic rendering of, anybody know what this is? What this is supposed to represent? That could just be a statement of our artwork, but this is a regression classification tree. So we have a bunch of predictors that are sometimes called features in the world of machine learning that we try to use to predict who is at high risk of having one of these events. So I just like this slide because it looks kind of cool. But this is kind of the typical pipeline for a machine learning kind of an application where you have the real work is all back here in the boring part, where you're trying to figure out if Luttrell is really Luttrell and things like that. But we have a pipeline of raw data that we process and prepare, and then we have what we call a training data set, and then we try to analyze the training data set using various statistical algorithms to come up with candidate models that seem to predict well within that. And then this, by the way, if you're familiar with issues of overfitting and data mining and things like that, those are obviously major issues in this type of an analysis. You then go to another data set that you've kept basically locked in the freezer across the street and say, how did the models work well in what we call our test data. Right? And that's really, I won't say a whole lot about this now, but that's Andrea's led an effort where we've been trying to use different types of machine learning approaches to see which seem to work the best. And a method that's called random forest generates the results I'm going to show you in a minute. So each person, when you come up with your favorite model, each person has a predicted probability that there'll be a call made. And then you set a threshold. You say everybody who's over a certain threshold I'm going to consider to be my at-risk group. And what's interesting, for those of you that learned econometrics, how many of you took a course in econometrics or statistics? We spend a lot of time using words like beta hat. No one? So, econometrics is kind of about the beta hat. I have y equals x1 beta 1 plus x2 beta 2 and so on. And everything is about the betas. Are the betas causal, and what's the standard error of the estimate of the beta? And what do I do if two x's are correlated? How do I tease out how do I tease out the beta for each one? And that's basically the core set of challenges in most of the statistics that I learned. Machine learning is all about the y hat. I don't actually care that intrinsically I may not care about the betas. What I care about is it predicting well who's going to have an emergency call? Like if I have two variables that are super correlated with each other, in most econometric analyses you're like, oh my God, I have a huge problem. When you're doing machine learning, hey, cool. That's great. Maybe if there's some random noise, just averaging the two of them, that'll be great. It'll kind of smooth out some of the noise. all I care about is, do they predict the why well? And a lot that's good and bad about machine learning comes from that. So we estimated using a random forest classifier, trying to figure out in a big data set, can we predict who's likely to have one of these behavioral health involved calls? And we compared what our random forest estimator said to what the dispatchers were doing. And in one respect, I came out of this thinking the dispatchers are actually pretty good at their jobs. If you look at people who had total red flags, like this is definitely a behavioral health emergency, how many times did the dispatchers did they blow it and just not get that? It turns out very, very, very rarely. So very few, if you look at sensitivity means if there was a behavioral emergency as determined by what happened when the ambulance got there and the kinds of notes that the ambulance folks left, the dispatchers were actually much better than the random forest that we have. I mean, 43% versus 30%. If the random forest labeled it as, hey, this is likely to be an emergency, it was actually much more likely to be an emergency than when the dispatcher does. The dispatchers were over-inclusive, which is probably smart, actually. You know, a lot of times they're like, I'm not sure what's going to happen in this call. I would like to send a mental health trained officer out there. Officer gets there, not needed. That's a hell of a lot better outcome than the other error, even if you could call what that first one is an error. So we looked at various measures. We were much more specific. What does specific mean? That means if there's not an emergency, how likely is it that the classifier will say it's not an emergency? Very specific, more specific than the dispatcher. We don't exactly know whether that's good or bad, but it really shows up as quite different. And then negative predictive value means if you say that it's not an emergency, how confident are you? So positive predictive value is if the flag is it's likely to be an emergency, how worried should I be? That's like you get an HIV test that says positive. How scared should I be that I actually am positive? That's PPV. NPV is the test is negative. How relieved should I feel? So there's different metrics that we use, and they all have value in different ways. So we can identify specific people. So now what do? Can we actually use that information? This is from a programmatic point of view, I think the most important part of this whole otherwise boring presentation. The fact that there was no laughter in that is deeply concerning. That's deeply concerning. So we're doing this pilot. Amy Spellman, I think, came up with the name MHEART, which is Mental Health Emergency Alternatives and Referral to Treatment. Basically, the entire thing comes down to can we come up with a good name? And we did. So now we should be funded. So what we try to do is use the results of these types of analyses to come up with lists of names of people that we then try to find and recruit to treatment. So, and this involves all these partners, the city of Chicago, the fire department, the police department, Thresholds, which is going to provide the actual mental health services, NAMI, which is assisting our outreach workers, and the 2 urban labs that are involved in this. What we're trying to do is to proactively engage people into services. Now, there's one really big and stupid complication, which is kind of unavoidable, at least at this stage. Police data, arrest data is basically pretty public, but ambulance data is HIPAA-protected data. I can't just go and say, I wonder if Gene had any ambulance calls. That's protected health information. So we cannot directly give information to Thresholds in the way this is set up now. That's not HIPAA compliant. What we have to do is send out our own outreach worker who works for me, who then says, you know, Gene, we've seen that you've had some challenges. We have some services that we think could help you. Would you be willing for me to share your name with the people at Thresholds so that they could provide you with some mental health services and some other things that you might need? And if Gene says, yeah, that sounds like that would be good for me, then I can give Thresholds Gene's name. So it turns out that the hardest part is finding Gene. especially some of these people, they're homeless, there's 7 different addresses where there's been an incident. When people are actually directly engaged, they're pretty receptive. But I must say, this is the part of the project that made me personally the most anxious by a wide margin, because I'm not a mental health professional or a manager of mental health professionals. I'm a researcher. And people said, who do you want to hire as your outreach worker to go and approach you? And I was like, that's easy, LeBron James. Because, I'm worried about my staff. Well, LeBron James is kind of busy and expensive. And actually what we have Jessica and Liberta, who Liberta is very grandmotherly, and Jessica is an SSA alum who's been out maybe 5 years, something like that. Not LeBron James. And they do an amazing job. But what we do is Andrea generates these lists. And I should say that if people consent to services, they typically get ACT. And I'll talk about some of the limits of that. But where they would be people would be going out to them. But one of the major reasons to do ACT is you have someone who's not going to come in for services, who has issues in their environment. You want to go to them and deliver the service. People with the right diagnoses, Medicaid will pay for ACT. Okay. So we have this pilot in the field. We have, I believe, it's been about 4 weeks. It's kind of a wild ride for all sorts of reasons, but it's working actually quite well. And I'll tell you a little bit about some of our experience. One thing that we do is we look through every arrest, every ambulance encounter for each person to try to understand, are they people that are likely to benefit from what we think ACT has to offer? And also, is it safe to send Jessica and Liberta out to try to talk to them? And especially in a pilot stage, I'm pretty finicky about that. And if we see things like involvement in weapons, I'm like, next time. A decent number of these folks have some sort of a mention of a sexual assault type issue, and I'm not particularly enthusiastic about having them in our pilot either, because we're learning how to do this well. And so we do some culling for safety. 13 individuals have consented to services so far. We've committed to do 20, and we're on a path to do that. And they are actually pretty receptive, although whether they stay in services is another thing. And one of the challenges that we have is a lot of these folk, they definitely need help. But it turns out what they need doesn't exactly match what the ACT model is set up to do, or they don't have a diagnosis that is reimbursable for ACT. So like say you have a guy who just has a bad alcohol problem, and he's just getting into a lot of issues because of his alcohol disorder. He definitely needs some kind of intensive treatment. That's actually not an ACT reimbursable thing. Or he needs housing. A lot of people, what they actually, as Tony's question alluded to, what they really need is just a place to be. And it's finding ways to help people who have multifaceted needs that are especially around the social determinants rather than around a diagnosis, that's a big challenge. So a lot of those people are not going to stay engaged in services the way it's currently designed. And we have to do a better job. But another thing that we found is a lot of people, what time do I have to stop? 10 to? Okay, I'll be very, the other thing, but I'll just very quickly stop. A lot of people we're not going to be able to find, or they're too dangerous for us to go out and look for. We have to find ways to engage them when they show up for things, like when they show up at the ED. And that's really important. We also had a couple of impersonators, people who need services. They're actually not the person we're looking for, but they say, hey, I'm him. I definitely need ACT and housing. And blame the game, not the player. They're trying to get help. So these are the kinds of things that we're working with. I'll stop here. I'm sorry, I went a long time, but thank you very much.